Okay, so my case is what I call the hostile aorta. I will go over the case. 68-year-old patient was admitted with progressive shortness of breath. It has been progressing more and more for the last 1 year, actually. Found to have severe aortic stenosis and left main disease. He was planned for surgery, but because of porcelain aorta, he was referred back to us. Okay, thank you. Echo showed normal ejection fraction, severe aortic stenosis, peak gradient of 87, mean of 54, aortic valve area of 0.7, and aortic valve area index to the body surface area of 0.5, which is actually qualifies for critical aortic stenosis. This is actually his angio, as you can see, distal left main, calcified, involving the ostial LAD, and circ is occluded, and there is a ramus. And as you can see from this iliocranial view, I don't know the pointer here. No, okay. You can see the calcification of the aortic annuli and the aortic sinuses and the ascending aorta. This is the right coronary. PDA ostial, we said just will ignore it and concentrate on the left main. This is the echo. As you can see, there is the concentric LVH, calcified aortic valve, limited mobility, velocity of across the aortic valve more than 4 meters per second. So we elected to put an abitur for many reasons. One of them is the coronary access is very crucial in this case. The restenosis rate is high. You have a stent in the left main, relatively young patient. If he comes again with instant restenosis, you want to have an accessibility to their coronaries. Also, you have the calcified aorta, porcelain aorta. You need a system which is very flexible to deal with. Also to avoid post-dilatation. In these cases, trying to prevent what they call annular rupture. And the measurements, the coronary heights were okay, and perimeter, he falls into the middle of 25 millimeter size valve. So this is the system there is large cells for the coronary access, and also there is outer cuff here to prevent the PVL, and this is the delivery system. It has a safety knob here. So when you reach 80% of deployment, the knob will pop out. So no matter if, sometimes when we do other systems, without intention, you are just rotating, and you are in no way to come back. Here, just the knob comes up, and you cannot proceed with full deployment till you press on the knob. So this is a very safety pin. The other thing is the system is very flexible. It can negotiate through different anatomies. And the nose cone is tapered and soft. And also, we didn't have any problem. So far, we did about 18 cases, and we didn't have any problem in introducing it. This is one case, actually, where it shows how flexible the system, going even in the TAVI grafts. Also, a different anatomy can accommodate, this valve can accommodate, like horizontal aorta. So we go back to our case, PCI and TAVI. Do we do it in the same session? You have a left main, which is calcified, a very high risk intervention. You have a critical aortic stenosis. So do you do it in the same session? Or the fear is that if you do it in the same session, the problem is when you finish and you need to reverse the heparin, because you have to close the hole with the ProGlide, and if ProGlide fails and you need to reverse the heparin, you have a fresh stent in the left main. And if it closes, you are done. So this is one. Second thing, what about the sentinel device? He will be a perfect candidate for that. Actually, we don't have it. Yes, the trial with the sentinel device was negative, But I think we have to be very selective. In certain cases, really, you need that kind of device. Luckily, this patient, we did him, and he left home after 48 hours without any, we didn't have any neurological problem. Because as you can see, the aorta, how calcified it is. So we went ahead and did the left main. So a stent, the circ was occluded, so we left it, just the protection wire in the ramus. And the left main LED was taken with a 3.5 by 33 stent, post-dilated the proximal part of the stent with 4.5 balloon with excellent final results. Okay, so after more than a week, actually, we called him back for the TAVI. And we started it. And crossability, usually we use most of the cases, 90% of the cases, we use the JR. And we cross with the straight wire. So we didn't have any problem with the crossability. And then pre-dilatation, we did it with subsized balloon. And then, as you can see, starting to deploy, we deploy the balloon here, and as you can see here, there's a mild PVL, which clears within less than 3 beats.
So you did not pre-dilate, Doctor?
We did pre-dilate. Navitor, because, you know, it's a trade-off, doctor. You know, the more large cells, less radial forces, good coronary access. More cells like the evolute, the more radial forces, but you know the coronary access will be a bit challenge here.
Yeah, so it's the issue of you know, this is a heavily calcified. Not only the valve is the ascending aorta. Here is like some of the people, they opt to undersize the balloon for not touching that the fragile slabs of calcium in the ascending aorta, and I've been reported there is a case with aortic dissection. So what do you think, if you don't mind, Dr. Almukhaini, I will ask.
Yeah, please go ahead.
What do you think, Dr. Abdullah Saidi, for example, if the LBOT diameter 22, you will use the 22 balloon, or you undersize to avoid touching the ascending aorta, or?
Yeah, I agree with you. Basically, it depends on the extension of the calcium. If the calcium extended all the way down to the LVOT, then probably you have to be somehow less meticulous in using the sizing of the balloon. But, you know, this kind of valve, like intraneural valve, especially with the amount of the calcium, I think pre-dilatation is a good choice here in this case.
So, Waqar, to avoid the hassle of pre-dilatation, would you go for balloon expandable valve here?
I think you can. There is no contraindication to balloon expandable valve, but I don't even see the contraindication to pre-dilatation. So you could go either way. I think it would be easier to use whatever valve you're used to using. This valve is marketed definitely as being more deliverable, more flexible in terms of delivery in hostile aortas. So it's definitely an option.
So, Dr. Thani, coronary access is very important in this patient.
Yeah, correct. Yeah, having the coronary access just in case. Down the road, probably this patient might have restenosis in the future. So, I mean, the choice to take him in the first place to the TAVI, with this kind of aorta, and this type of valve. So coronary access is of prime importance just down the road in the future.
And also this, the valve, you don't need to check under fluoroscopy the loading. Immediately if it is loaded, you don't need to check it immediately, go and insert it. So this is another advantage of it. As you can see here, the valve is well deployed, and the distance about 3 to 4 millimeters from each side. Very nice. And as you can see, the echo here, not even a trickle of PVL. And the mean gradient is, this is another view from the typical 3-chamber view. Actually, you can see there is no PVL. And mean gradient was 4. Patient had transient left bundle, but he was maintained in sinus rhythm. There was nothing, so we discharged him after 48 hours to come back again just to check his Holter after 2 weeks. As you can see, the mean gradient is around 5. Thank you very much.
Great.
Thank you very